So we are in week 5. It's a big week. It's cardiac, it's respiratory. I'm just going to try to hit on those key concepts so that I don't keep you here all the way to the end, because by the end of listening to cardiac, your mind is going to be like this because it is a lot to understand. Now, did you all have a chance to print out that matching sheet I sent you? That matching sheet in the announcement covers everything you need to know about these 2 chapters. It goes over the medications, it goes over conditions, it goes over very important things. If you want, I'll connect it here for you also so that you have it. I mean, this is how much this is that you will need it. It's actually the way you should study this week is through, can I take care? Do I understand this one? So there it is on the side. You can take and download it. You all have it. And you're going to see it's 20 questions. I used to give this as a quiz to my students that they would understand what was what was what. So, and that was when I was on ground. That's back in 2019 was the last time I gave it. So there you are. It's a great tool. Use it. So here's our PowerPoint for today. So the first thing we're going to go over is respiratory, breathing, children. If you don't breathe, you can't breathe, nothing else matters, does it? So there are types of infections. In children, probably 95% are viruses. And there's all different names for all different viruses, with children, right? Upper airway swelling, croups, and, upper airway with mucus, ear infections, that's all upper, okay? And then lower is going to be more of your asthma or more of your pneumonias, aspiration pneumonias, etc. So, as I said, most of your upper respiratory in children are viruses. Now, one of the big ones that we talk about is respiratory syncytial virus, RSV. For you and me, it's a common cold. But for an infant, they're having a hard time just sucking, swallowing, and breathing. And they're obligatory nose breathers. How can you suck and swallow and breathe with a bottle or a breast in your mouth? That's the problem with the younger children. So we need to clear that airway. And they have low-grade fevers and they feel miserable. So we need to get those fevers down so that they will want to eat more nutritious, whatever that food is, right? RSV is okay with a normal infant. Yes, they're going to have difficulty breathing. They're going to be a little tachypnic, tachycardic because of the extra mucus in their nasal passages. But what if this child also is a cardiac child, premature child on oxygen, child who has some sort of lung conditions, cystic fibrosis, or etc.? That child would be at high risk if we allowed them to get RSV. So there is a monthly vaccine, and it is called Synagist, and we're going to get to that again, but I wanted to mention it. Now, if we're for respiratory infection and it keeps going for more 3 to 5 days and still with fevers, that's when they start treating it with antibiotics because most of upper respiratory are virus. Now, young infants will always be our concern because they're not making all the antibodies and they're losing all of mommy's maternal antibodies. And we're being exposed to all sorts of germs, right? Finally, at 3 months, usually that's when maternity leave is done. And then they're in daycare or with other children, and now they're exposed. And we know that exposure is going to lead to that child getting multiple other infections. Now, yes, the child's sick, but the child's building immunity. That's the trade-off right there. We know toddlers, they go to daycare and all day long they swap spit from toy to toy to toy. There's no other way to say it. All they do is exchange germs all day long. Again, they're preparing their bodies and giving themselves this immune system. So by the time they get in school, they have already built up the immune system and they're not going to have to be out so much with absenteeisms because they already have a stronger immune system. So ear infections. Well, think about mucus in the upper airway and children. Do they blow their noses? Do they know how to get that stuff out easy? No. So what happens? You have eustachian tubes that are in the back of your throat, and you have all this mucus in here. Where does this mucus go? Area of least resistance. Up these big, wide open structures called eustachian tubes, up into the inner ear, creating inner ear infections called otitis media. Okay. And it's because of these short, wide open eustachian tubes. All that mucus they're not getting rid of. It's area of least resistance into the ears. Now, children, what do they look like when they're sick? Well, if they have a fever, they're going to be sitting in the corner, not playing, not wanting to drink their favorite juice, and not want to eat. And they might even be whining and crying because they just don't feel good. So once we figure out they have a little fever, to medicate them for fever, to bring that fever down, these children all of a sudden go from the sick looking child that maybe don't want to eat, that maybe tummy hurts, sore throat, little cough, all of a sudden fever's down, they're up running around better than they were, and now they're drinking fluids and maybe eating a little bit. The reason why we medicate for fever is, how do you feel when you have a fever? You feel horrible. Well, the kid does too. So you bring the fever down, they feel normal, they eat and drink, which is what you need. When you have a fever, you need those extra fluids. So that's a kid. Our goal with anything respiratory is to have them breathing easier, rest easy. I mean, one of the big respiratory conditions, bronchitis, is that awake all night long with that dry, bothersome cough. All right. That's bronchitis. We need to do things to make sure that child can rest. Keep that infection, using tissues or in the arm. I know my grandson who went to preschool, all of a sudden he was in his arm coughing and whatnot. I thought that was pretty quick how that happened. And how to wash their hands, keeping their temperatures down. Then you can promote nutrition and hydration. And of course, they always need those hugs. Now, anybody ever hear of infectious mononucleosis? Isn't that another word for kissing disease? That's not a big deal, right? Well, mononucleosis presents as a sore throat, swollen glands, maybe a rash, almost flu-like, achy, feverish sore throat symptoms. That's what they feel like. They feel icky, just tired and weak. It's what they call herpes like Epstein-Barr virus. Epstein-Barr virus is notoriously that fatigue syndrome. That's what it's referred to as. So these children will go to the doctor complaining of a sore throat. They're going to do a culture and a strep test. Everything's negative. They're going to be sent home with just a pharyngitis viral because they couldn't find anything. And they'll be given acetaminophen, ibuprofen, alternating, increased fluids, and rest. Well, about 3 to 4 days later, they're still sick. So they call the doctor or they go in and then they get antibiotics. They still don't feel better 3 to 4 days later. Now they're in my ER on a Saturday morning. And I'm going to give you a story. A little 8 or 9 year old boy came in one Saturday morning with his father, complaining of sore throat, swollen glands, was on antibiotics, was still sick. So our doctor looked at him and said, "We need to do labs." Well, what lab work do you think we needed to look at? Well, a CBC. What does that show me? White blood cells. Elevated white blood cells will tell me what? It's a bacteria. Well, these kids were normal. So they were normal white blood cells. So it's a virus. We also do something called a monospot test, and it showed positive. Now, what's our treatment for monospot? It's a virus, right? So your achy pains like you have the flu. So acetaminophen, ibuprofen, alternating, fluids, rest. And we have swollen glands, and it could be a swollen spleen or a swollen liver, like sizes of balloons. No contact sports, as in protect the abdomen. Those lymph nodes, spleen or liver could burst if it's hit hard. Let me tell you, 1 week later, this little boy, after the doctor gave great instructions to both the father and the son, also, I gave instructions about avoiding contact sports. They needed to get clearance about 3 weeks into it by the pediatrician before they could even continue PE, right? Well, week later, I'm the trauma primary nurse on call, which means anything in a helicopter that comes in, I'm in charge. I run it. So we get a call. It's from the Everglades. This 9-year-old boy was on the back of an ATV, fell off, hit his abdomen, and he arrived dead on arrival. He popped his spleen. I'll never forget that, ever. I was the one on duty, and the doctor that was on that day was there. And we both looked at each other and cried. We're like, but we gave such great instructions. So, as I pass this forward to you, anyone who works pediatrics or knows someone with mononucleosis, make sure they know to protect their bellies until cleared by their physician, because their glands get swollen and it will pop like a balloon. Bronchitis. This is the one that you're awake all night long coughing. It is known, and this is the definition: dry, hacking cough, non-productive, worse at night. This is the one that you need some really good, strong cough medicine, in order to take care of it. I mean, when we look at bronchitis in adults, they always give us a Z-Pack, and they also give us a some sort of Medrol dose pack, steroids. That's usually what the order is. In children, they might order a steroid, they might order an antibiotic, but it's that cough medicine and that anti-inflammatory steroid, which can help. And they'll say, put a humidifier in the room. That extra moisture helps. Okay, respiratory has inspiratory problems and it has expiratory problems. Okay. What would be an inspiratory problem? It's the upper airway. This is the epiglottis, the trachea, the tonsils. All this back here is swollen. And then air can't get in because that passage to get down in your trachea is swollen. And the epiglottis, of course, is swollen. That covers the larynx when you swallow, right? So preventing aspiration. Croup is always inspiratory problems. They can't get air in. And once it gets in, you're going to hear them barking. If you ever hear a seal barking, this is exactly what croup sounds like. And it's usually, again, a virus. We treat it by decreasing inflammation, steroids. One dose, several dose, one injection, one pill, they're all different, depending on what they do. Now, croup is easy to treat, but if we allow it to continue, it can become a big, big problem. As I said, it's mostly viral. Now, again, what do we see? Everything in is hard, it's swollen, air can't get in. So, inspiratory stridor. And then, of course, you're pulling hard to breathe in, substernal retractions, and of course, that big cough that you see. If it continues, and when that swelling's there, hard to get air in, with this cough, it can lead to respiratory acidosis, respiratory failure, and acute epiglottitis. Remember what the epiglottis is. That's that leaf-like structure that covers the larynx. You swallow, right? Why doesn't fluid go down into your lungs? It's because the epiglottis covers it while you swallow. Like Lindsay, you just had a sip of water, right? It went into your stomach. It didn't go in your lungs because the epiglottis says you're not going there. And that's what it does. Well, What if that gets all swollen up and now air can't get into the larynx at all? That is epiglottitis. So, nursing responsibility. Well, we know without an airway, there is nothing else. Nothing else matters. So, to protect the airway, you always make sure you have a trach tray and an intubation tray at bedside. Those things you need there, just in case they have to do something more to get this patient to breathe. What you see with epiglottitis, you'll never forget. These children are pale. They're usually wheeled in because they can't walk. They don't talk or they go. That's this really garbled talk. And they're just drooling. They can't swallow any secretions. And you'll see them leaning forward, trying to find a place where they can breathe. Okay. This is a child that needs emergent care and needs an epi aerosol immediately on that throat. So these children come in first thing. What am I going to grab? I'm going to grab my epi aerosol and I'm going to get an albuterol aerosol, both of them. And I'm going to walk in the room and start that epinephrine aerosol. It's going to decrease the swelling and allow more area for air to pass down into the lungs. Okay. We always worry about hydration. Well, at this point, they can't eat or drink. So an IV fluids would be good. And also they say after you give the aerosols and we've opened it up and there's air now moving, we can do a nebulized type of air mask or something. They got really neat ones today. And it's really good moisture that comes out. And of course, steroids, IV steroids on epiglottitis. RSV, talked about it already. We know this is that infant under 1, so up to ages 1, we'll call this RSV that maybe will need immunizations, monthly, okay? We don't want children that are already struggling to suck, swallow, and breathe to have to work harder to suck, swallow, and breathe because their noses are clogged up with something called RSV. So we give them Synagist. It's also called palivizumab. It's a biologic. And we give it monthly, only the first year. And then these children don't get this viral upper respiratory infection with all this mucus. And again, they don't need to. They're already sick enough. Another thing children get is tonsillectomies, adenoidectomies with tubes, and sometimes all together, all at the same time. Now, tonsillectomy instructions. Today, children go right home after surgery. They feel that children do better at home. They recuperate better. Mom's there, grandma's there. They have their own soup, juices, whatever it is, and it's a better environment. Now, as nurses, we need to teach them well. So the foods they eat must be just very bland. They say highly irritating, spicy foods can irritate. Think about what they do in a tonsillectomy. There's these big tissue that stick out in the back of the throat. They take a scalpel and they cut it, and then they cauterize it. So you're left with scabs in the back of your throat. And that's what that nasty taste is, and that smell is for about a week after surgery. Now, we know scabs like on elbows and knees can break off and bleeding can occur, right? So that's why no spicy foods. We want to maintain the integrity of that surgical site. No gargling, no vigorous toothbrushing, and their breath smells. So they want to brush their teeth to get rid of the smell, but it's not going to go away. Analgesics, they used to use codeine type stuff anymore. They say acetaminophen, ibuprofen are absolutely just fine and it works. And they should be 1 to 2 weeks bed rest. Now, I have seen 1 week old, just came from the doctor follow-up visit. Little girl came into my triage room vomiting big clots of blood. I had to put a big bucket in front of her and she filled it up. And this is immediately after being seen by the ENT. She was good. She got a good clean bill of health. She came to me and vomiting. I literally had to pick this girl up, run into the resus room, the trauma room, call for help, get an IV started, and I gave her a whole liter of normal saline. That's how I mean, she was going into shock. Heart rate was 160, blood pressure was 70 over 30. She was ready to go. Flew it in, went up to the OR, they recauterized, and she was fine. So, tonsil's not a big deal either, are they? Again, it's following instructions, keeping them safe, watching the foods, stuff they put in their mouth. Another thing is, if after that 5 to 10 days that the smell is getting bad or they start persistent fevers, that's something that should be going to the doctor and checking it out. Now, pneumonias. Pneumonias could be due to many things. It could be due to bacteria, virus, mycoplasma, could be due to food, aspiration, or it could be inhaled like powders and chemicals, right? All of those things. We do have some vaccines out now, which are great. We do give them to young kids, to prevent them because that really bad pneumonias are really, can take a lot of toll on a young infant. Remember, it's airway. We know that aspiration pneumonia, as I said, is that difficulty feeder and teaching parents how to feed their children and burp them well, set them up, and again, watching out for chemicals around them. I mean, I've even had students come in and tell me they cleaned the bathroom with bleach and some Ajax and the combination, and they inhaled it and their lungs were burned and they had aspiration pneumonia because of the chemicals. Well, think about kids. They're going to get it too. And as much as I love Johnson and Johnson baby powder, I think it smells wonderful. Powder on infants shouldn't be done because they'll get powder in the air. Now, foreign bodies. What do children do? Everything in the mouth. I've seen many things, but coins. The one thing that I still to this day don't understand. Of all the coins, the one coin that children love to swallow is a quarter. Not a dime, not a penny, not a nickel. It's the quarter. It's the biggest one. And like that picture, that's a picture of one of my kids. It was right there, right in the throat, right there. So, how do you think we got rid of it? They don't go to the OR anymore. We don't do bronchoscopy anymore. I was shocked the first time I saw it, but it was like a 4-year-old little boy, and he was breathing all right, but it hurt. It was right there, caught, couldn't get it out. So what we did, we got the surgeon down there. The child sat on the surgeon's lap. The mother was next to him holding his hand. I was there in front of him, and we stuck a Foley catheter down his throat, blew up the balloon when it got below it, leaned him forward, and told him to cough. And when he coughed, the surgeon pulled it. And when he pulled it, he vomited the quarter up and mucus. And I distracted him. I said, the first one who gets the quarter gets to keep it. So that child wasn't worrying about the surgeon pulling. He was worried about getting on the floor to get the quarter before anybody else got it. And the mother was like, how did you do that? He wasn't even scared. It's that distraction. It puts them, that quarter was more important than it was what was going on because he had his people around him and he wasn't afraid. He had really good teaching. Pertussis is another respiratory. It is an immunization, but not everybody gets immunized. No, it's extremely contagious. It requires reverse airflow rooms, and zithromycin is the treatment. It is a bacterial infection, and these kids get sick. Smoke inhalation, know that, if there's a fire, one of the one things we do is 100% oxygen, and monitor them. We've even seen them going into those the tanks to put them underneath. submerge them underwater in those things. I've seen them during like hurricane things down here in Florida with smoke from generators and stuff from years ago. But it's 100% oxygen is what we're going to look for. Remember, children do not tolerate cigarette smoke. Secondhand smoke causes ear infections and a lot of other issues with them. SIDS death, ear infections are the two big ones that you'll hear about smoke. Cystic fibrosis. This is a multi-system issue. This is the lungs and nutrition. The small intestines does not absorb fat. The pancreas doesn't work right, and fat just goes straight through, and that's why you have these horrible stools, foul smelling, greasy stools. It's all the fat. We don't absorb it. So what would you see with cystic fibrosis? Well, if we didn't know a child had it, when we usually do today before birth, we test mom and dad, but let's say they weren't. This child's skin would be tasting like salt. If the mother licked their child, it'd be like licking a salt stick. I mean, that's how salty it is. And they do a test called a sweat test, and it's testing the salt in the sweat. Because of the lungs, there's mucus that just fills it up. It's like these big, thick petri dishes, and it's filled. And I think it's like they grow bacteria all the time. They're constantly with infections, PICC lines, getting aerosolized antibiotics, all sorts of things. And then they've got this dietary issue. So they can't breathe. They're working hard, burning calories. And now they've got this diet thing. They don't have fat, which is the highest level of calories. So these children are skinny kids that can't keep their nutrition. They can't. They have to eat high protein, high carbohydrates, low fat. Because they eat high fat, it's just going to come out in the stool and they're going to lose more electrolytes and everything else. Now, cystic fibrosis. That's the sweat test, like I told you. Treatment is taking care of the lungs. That is that chest CPT. They've got those vibrating chest things today, which are wonderful. Knowing that cleaning equipment in between usages, or at least once a day, because all of that mucus gets there and chances of infections. And then that's just the lungs. Now you have the dietary. So every time you have snacks or meals, they need to take this pancreatic medicine, the one that I hear all the time is pancreatase, and you take it before, immediately before, not 2 hours before, immediately before they eat. If it's capsules, you can open them. It's fine. You just can't chew or crush these little tiny little pellets that are in there, little tiny little beads. Okay. If it's powder that we're using, because it's easier to measure, again, washing the mouth out, just like we do with some of those aerosol medicines that we give adults, right? Like Symbicort, Advair, Brio, those things. But rinse the mouth out to protect the teeth. And the one thing we forget to do is as children grow, increase the dose. I think I have in my career seen that a lot in seizures, where we forget to increase it, or that child had a big growth spurt and then they have breakthrough seizures. So, same thing, they're not going to get the nutrition they need. Remember, because this is something to do with the pancreas, these children are at high risk for diabetes in the future because they already have a damaged pancreas, okay? So our goal, let's keep those lungs clean, let's keep them free from infections. These children and that are going to be adults really need to be up and moving, good physical exercise. I will always say swimming is number one. Swimming, holding their breath, going underneath, it makes their lungs pop. It's like giving heat to those lungs, keeping those lungs open. So again, up, out, moving, giving the medicines, aerolized antibiotics, IV PICC lines, whatever needs to be done. Again, high protein, high calorie, low fat. And we're just trying to keep that stomach moving. All right. Cystic fibrosis and pregnancy. This was a question off of a HESI. There was a question regarding, can you get pregnant when you have cystic fibrosis? Now, as a woman, yeah, you can get pregnant. It will be high risk, but you can get pregnant. Now, a man cannot impregnate a woman. There's something to do with mucus and the vas deferens, and they can't get the sperm to the woman. But if they do a bilateral lung transplant after 1 year, they can get their wife, their partner pregnant, which many men do. And that was a question that I did see. Sleep apnea is just like adults. Kids get it. You take out tonsils, adenoids, you do all these things, and they're still snoring. And if you allow them to snore, they're not getting good rest, just like adults. Give them that they do the sleep study, give them CPAP, let them know that they can sleep better. They'll be better, well-mannered, behaved because they're not tired children. ARDS, lungs have been hurt somehow. The biggest thing is sepsis. Children infection, remember, they're just getting, shown these bacteria and viruses, and their body has to build up, their immune system with it. So sepsis is huge if it gets into the lungs. Of course, any trauma, drug overdose. And what about the child who's a near drowning? Now, one of the things with near drownings is, I work in South Florida. I've seen children come in that were on the bottom of the pool out. The parents got them up, or the next door neighbor, whoever it was. By the time the ambulance came, they were up and running around and looking fine. Does that child need to go to the ER? They can have lung damage up to 72 hours later, delayed. These children must be watched in a monitored area on an O2 sat monitor minimum, because they can crash up to 72 hours later. So that's a different thing for you.
Isn't that called second drowning?
Basically, yes. And it's just part of the initial is because the hypoxemia and that water filled up the lungs. And it's that moment which causes those things. One of the ways we can treat them is something I actually got certified in this. This is ECMO. This is where they take blood out, they oxygenate it, and they put it back in. It does not work as a heart. It only oxygenates lungs on children, infants that are born with meconium aspirations or other bad problems with their lungs. And this keeps the child alive while we get that whatever fixed.
They use this a lot during COVID, right?
Yeah, COVID was used a lot, especially in the adult world. Yes, absolutely. But it's interesting to watch it and to play with it. I always like to play with things, so of course I had to figure it out. Remember CPR. When you're any exam, always catch yourself up. This slide's basically telling you, remember, there's a parent or a guardian or somebody outside. Always remember them. I used to know that years ago, we would kick parents out of the room where their children was coding. Today we don't. We want them to be there, just watch what's going on, to hold their hand, maybe to be there for their last breath. So we keep them in there now. Another thing you need to remember with your CPR is it 15 to 2 if somebody's with you, or 30 to 2 where you're alone CPR. And what happens if a child chokes on a toy? Abdominal thrust, back slaps, right? Know those things. You're going to see them again. Asthma. Asthma is not inspiratory. That's croup. That's epiglottitis. Asthma is the lower lungs get inflamed, something irritated them, some sort of hyper responsive, and they swell up and air gets caught in the lungs and you can't get it out. This is that child trying to get air out, coughing, 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 coughing. And then you hear that, trying to get the air out. I know my husband went to status asthmaticus, and listening to his lungs, all I heard was at the end of a breath. That was it. It gets to be that insane that much. So how do you treat kids with asthma? Well, if they're having an asthma problem, wherever they want to sit, wherever they want to go, let them go. I want them to be not upset, have parents hold their things, whatever has to be done. I have found that it works the best. Put the mother in the bed with them, father in the bed, brother in the bed. I don't care. If the kid's gonna sit there and take their aerosols and relax and be comfortable, that's what takes care of asthma attacks.
A doctor also told me that even if the child is crying, like just let him cry. It's better. It actually opens up the airways better when they're doing the treatments.
Exactly, because it gets deeper in there. Yes, yes, yes. Even with the spacers, that little thing down there, those little white, blue, pink, and orange, you put it around the mask. You give a little bit, and the little kids cry like crazy, but they take a deep breath in. So now they're getting their medicine good. We will test for androgens. We try to figure out cocktails that will desensitize them, especially if they're really sensitive. And then the other thing is, can asthma kids play sports? Absolutely. But you're not going to put them on a grassy field if they're allergic to grass. You're going to put them in a swimming pool or bowling or tennis or something else, right? You have to work within their limitations. So adults, children, don't matter. You need the long-term control medication. That in children is Pulmicort, morning and night, has a little bit of steroids in it. In adults, we've heard Symbicort, Advair, Brio. That's the one that with a little dose thing that you have to rinse out and rinse your mouth after each one. Same thing with these children. We have our rescue MDIs, albuterol, Proventil. I mean, they're different names, but they're that rescue one. And then, of course, we have steroids when they're in that really bad time. So status asthmaticus. This is when that child, my husband who did it to me, just started not being able to breathe, started coughing. And then you saw the restlessness starting to occur. And he couldn't even sit in the bed correctly. He was so anxious. Children get this way. And again, it's just trying to put them in a place where they're the most comfortable. Yes, you're going to give them whatever aerosols they need. And we give back to back to back. That means continuous albuterol aerosols can be given. We're going to give steroids. Solumedrol is the big one, and maybe aminophylline drip, which also helps. We know COVID, we know there's all levels of it, and we know there's immunizations today, and we're still learning about it. Now, let's look at our heart. When we look at heart, there's congenital heart defects and there's acquired. There are cyanotic, which means you don't have enough oxygen, which means you're not above 92. And then you have acyanotic, which means they're not cyanotic and they have perfect O2 sats, but something's maybe a hole in the heart or something. If it's congenital, they're born with it. And that's mostly the things that we talk about with children. There are acquired, and that could be, let's say, lupus attacked the heart, right? Anaphylaxis could affect the heart. Infection, viral infections love to attack hearts. So let's look at a drop of blood. If you do not remember how blood just goes through the heart and what the name of those valves are, you need to brush up on it. Okay, I'm going to go through it right now. Let's look at how the blood comes back to the heart through the right side, through the superior and inferior vena cava, and it just gets into that right atrium. It goes through the tricuspid valve into the right ventricle. And then it goes to the lungs through the pulmonary artery and gets all oxygenated. Comes back to the left side of the heart, through the left atrium, through the mitral valve, into the left ventricle, which is your pump. That's your engine of your heart. And it goes through the mitral valve and to the body. the aortic arch and down to everywhere your body needs it. So the right side of the heart has very low flow of blood. It just gets there, okay? The left side is strong. You got big flow going into the left atrium, and you got that left ventricle pumping, which is big pressure. So always in a heart, if there's a problem of that middle septum, that divider, blood's always going to go from left to right, and that's called shunting. Now, one of the big conditions that they talk about is something called coarctation of the aorta. And basically, it's a kink in a hose. Did you ever play with a garden hose and get a kink in it? What happens behind it? There's no water. In front of it, it might be squirting out a hole or something, or might be squirting water out at the faucet, right? So if after that little red coming off the left atrium and ventricle, those three little subclavian arteries that go to the upper body, and that goes down, let's say it's kinked, it's a narrowing, it's a stenosis, it's all the blood can't go down. What would you see? What would be symptoms? Well, if blood is not going down, you would find it by very weak or absent pedal pulses, dorsalis pedis and posterior tibial pulses. They're not going to be there, or they're going to be very, very weak. Now, if I find that happening, I'm suspecting it could be coarctation. I'm going to do a 4-extremity blood pressure. And why? Well, blood's not going down, so your lower blood pressures should be lower. And because the pressure has to go up, the upper extremities are going to be higher. And where is that blood going if it can't go down to the toes? Well, it goes the only where it can. It goes back. It goes to the upper extremities, goes back in the left ventricle, up the left atrium, and into the lungs, and fills it up. And now you're in congestive failure. Coarctation of the aorta leads to left-sided failure, which is fluid filling up the lungs. These are the symptoms that you would see in this child. Now, any child that has a kink somewhere or is not flowing the blood the way it should, you're going to see some really obvious symptoms. Well, on examination, this is going to be a kid who doesn't eat well, tires out. Their weight's going to be failure to thrive. It's not going to be enough. They're going to be tachypnic. They're going to be tachycardic, tiring easily, of course, activity intolerance. And because they're not getting nutrition developmentally, they're going to be behind, period. It's going to happen. So these children, our goal is to decrease the amount of stress we're putting on them and let their heart get better, and then we need to fix it. This is an awesome nursing diagnosis. Inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed. And guess what? No weight gain, failure to thrive, you're going to have low weight. Now, cardiac kids, you can see by looking sometimes. Sometimes it takes more than that. I know that got to the point where I could put my hand on a chest and I could feel murmurs. It like buzzes. It's like, and you sort of can feel it when you're looking for those things. We know that children, cardiac, we look at all stuff. I mean, if they're breathing fast, tachypnic, we know nutrition's going to be a big problem. This is a child we're going to increase calories in the feed and have them with the decreased amount that they need to eat. They're going to tire out so quick, right? That's going to be this child here. When we look at the chest, we might see retractions. We might feel that buzzing going on. If we listen, we can hear murmurs. We're going to look at heart rate. Is it fast? Is it slow? Is it irregular? And all of those are normal. We can have that. We're going to do an EKG. We're going to do an echo. And if we find anything, that child's going to go for a cardiac catheterization. And that cardiac catheterization is going to find out what's wrong with that kid. What do we need to do? And then there's something else that's diagnostic. Now, interventional is a little different. Let's say you have a kid who's having these periods of supraventricular tachycardia. All of a sudden, the heart rate goes up and down for no reason. Usually there's a foci in the right atrium that gets tickled, and every now and then it beats fast. They're going to go in and do what we call an electrophysiology study. What they do is they try to reproduce this elevated heart rate, and they go in with a laser and they zap that spot in that right atrium and stop it. And that's what the interventional is. Now, nursing care of a child back from a cardiac catheterization. Now, sending them, you just send them, have them MPO. So this is only 2 hours before. We tend to feed our babies up to almost the time because we're worried about blood glucose levels. Postoperatively, this child's going to come back. Number one thing I'm going to check is their dressing. They put very big catheters in the right femoral artery and the right femoral vein. And when they do that, they check out what's going on and they pull them out. And then they hold pressure and they put a pressure dressing on there. But with the movement of the child going from the bed and the cardiac cath table to their bed or their warmer or their whatever, that scab could have jostled and it could be bleeding. So always check that dressing first to make sure. Well, what if it is bleeding? You're going to take 2 fingers. These are usually more your infants, your young ones. Take 2 fingers right above the site, closer to the heart. And then you could see where the bleeding is and put good pressure and call for help. Sometimes you need to transfuse. Sometimes the doctor just wants to put on a new dressing, but just hold it. That's all you have to do. And we can see here the biggest risk is hemorrhage. These children are on 24 hours bed rest, and to keep that right leg straight, they will be either giving oral or IV fluids, depending on the child. And of course, we'll be checking glucose to see, did they get any glucose during the procedure or do they need some now? Now, congenital hearts, there's more of them than you really realize. One of the big groups of children that we're always concerned and always will look at for any sort of congenital heart defect is your trisomy children. These are your Downs. Now, you're looking at 21, 13, 18, and you're like, what are those numbers? Well, Downs, you usually think of trisomy 21. There is 18, 15, 13, 11, and a 9. I've seen 1 9. And I've seen the 1821. 9 was severely, many things going on with that child. But usually your trisomies are your 21 or 18. Now, there are many conditions that Downs can have at birth. And one of them is something with the heart. The most common is a ventricular septal defect or a hole between the 2 ventricles, the right and the left ventricle. As we go further, you're going to find out these poor little Downs children are more susceptible to leukemia, heart disease, and hypothyroidism. Poor thing, huh? These are things that must be monitored, all of them. As I said, you always go from left to right-sided shunting because of the pressure. Think of high pressure, low pressure. Now, defects. When there's a hole between the dividing, between the right and left side, it's called a septum. If it's in the upper atrium area, it's an atrial septal defect. Remember, blood always flows from the left to the right side. So atrial septal defect or ventricular septal defect, you're going to have extra flow coming back to the right side. All it means is that blood's going to be reoxygenated again. It's going to go back in the lungs again. That's the point of atrial septal or ventricular septal defect. You're going to have reoxygenation going on there. Now, the pink ductus arteriosus is your fetal circulation. When you hear that word or PDA, think of that's my place where I get oxygen when my heart can't do it for itself. PDA, think oxygen. It promotes oxygenation and cardiac output. PDA, this is when we have it open, when we need it, okay? We've talked about coarctation of the aorta. We know it's obstruction, backwards flow, lungs fill up, no pulses on the lower extremity, and blood pressure differences, upper and lower. Whenever you hear stenosis, always think of a narrowing. There's an opening, but it's just smaller. So whether it's in the aortic valve, pulmonic valve, any valve, they can sometimes balloon those open. Zahesi, the NCLEX, loves tetralogy of Fallot. That's your big cardiac coarctation. Those are the big two they like to talk about. Now, tetralogy of Fallot is a right-sided problem. It's when blood all of a sudden can't get through the pulmonary artery into the lungs. It happens. It either spasms short or there's a piece of tissue that flaps. That's something that occludes the flow. It's happened one time to me, and his name was Nolan. I'll never forget this little 1-month-old baby. It was 4 or 5 in the morning. I worked night shift a lot. And this baby, I was changing his diaper and just wiped his little mouth off, and he went into a TET spell. This is that blue spell. He went from an O2 sat of 100 down to 10. What is the treatment for a TET spell? What could I do? Well, I can do what we call a knee chest. Take the knees, put it up to the chest. It changes pressure in the abdomen and the chest area, and it will pop open what's going on and allow blood to flow. But tetralogy, older kids, what do you think they would do? You know, there are older kids. We do most of the surgeries, but sometimes, you know, these kids are caught late and we wait till later on. But they still can have TET spells. Naturally, they'll go right down to their knees. They'll squat. And it does the same thing. It's the knee chest, right? It will take that squat, make the abdomen push against the chest, will pop open what's going, and let the blood flow. Transposition of the great arteries, mixed blood flow. What are the two big great arteries of a heart? The pulmonary artery and the aorta. So they're switched. That's what it means. So you have lungs going and systemic going, and these guys aren't mixing. Fetal circulation is going to go away soon because mommy produces prostaglandins, which keeps that open. So we need now to keep that open. So we need to get oxygen to the body because it is going and they're not mixing. So PDA, we want to keep it open. We give something called prostaglandins. It's the same thing that mommy produces, but we will do a slow, continuous infusion of it. How do we know that patent ductus arteriosus is open and it's working? Well, there's two different things. Number one, you are going to hear a loud washing machine murmur. It's like a washer machine. You can hear it going. Another thing is many of these children at birth, cardiac, will be born and they will be doing like an umbilical artery catheter, an arterial line, an invasive blood pressure monitoring. And you'll be monitoring that blood pressure continuously. Now, a normal blood pressure on an infant birth is 60/40. A child that has a PDA open has what we call a wide pulse pressure. That lower number is really low. So it'll be 60/18. So we know it's open, we hear the murmur, and we look at the blood pressure and it's 18. Sometimes that PDA, we need to close it because a lot of times premature infants have this PDA, it's open, and we need to close it. This is just washing the lungs out with extra blood flow going there, okay? So we give something called indomethacin. It's an NSAID, and we give it IV. And as we're giving it, I like to listen. Is the murmur going away? I like to look. Is the blood pressure numbers coming back to 60/40? And I used to watch it going, okay? Know that prostaglandins, when we use it, like for that transposition, it helps that oxygenation, right? And it helps with cardiac output. There are times where we don't need it open. It's just there because it didn't close for whatever reason. We can close it and we'll give that indomethacin. So prostaglandins, indomethacin, you need to know them both. So there's a couple flows there. I've talked about them already. They're there. You can look at the blood flows, etc. Now, congestive heart failure. This is that PDA, that coarctation, right? That blood went and now it's up into the lungs, and this kid is full of fluid. Congestive heart failure. The heart can't beat to what it should. And let me tell you, if we allow this to continue, this heart beating against all this extra pressure, it's going to lead to failure. You're going to see the lungs full of fluid. So what do we as nurses, what do we need to do? Well, we want the heart to beat better. We want to give it something to help it beat better. And there's all sorts of drugs we do for that. Could be just digoxin, right? And we want to get rid of that extra fluid in there. Well, that's a diuretic. That's furosemide. Now, how do we know that we're getting rid of fluid? The heart's beating better. Well, number one, you're going to see decreasing daily weights, and you're going to see the heart rate and respiratory rate go back to normal, and you're going to listen and you're not going to hear all that noise in the chest. Now, if we have to give digoxin, it's just like adults. This is exactly what you learned in pharmacology. Know that even with infants, children, you count an apical pulse for 1 minute. In children, they say above 100, maybe 120, whatever the doctor says, because remember, there's a lot of different heart rates for whatever age child. We're going to be checking that potassium, those electrolytes. If it's low, we're not going to give it because it'll go into dig toxicity. We're going to go and check a dig level, the last one they had. And infants, they can't tell you they see yellow spots. They can't tell you they're nauseous, can they? Those are signs of dig toxicity, but they can vomit. If you see an infant vomiting, that's a child that you would say, hold the dose, let's call the doctor, and let's do a recent dig level. That would be one that I would do. So getting that kid heart beating more effective, fluids going away. Can you always try to maintain nutritional status, whether tube feedings or PO or increasing calories, less fluid, all of those things we'll do for this child. You know, clubbing happens in the older kids, not in your young infants, but your hands might look like that. I put that picture there for you. And the other thing I wanted to mention on this slide is polycythemia. Does anybody really know how polycythemia occurs? It happens when you have a lack of oxygen. So your body says, you don't have enough oxygen. What can I do to help? Because the body's always trying to help you do something. Well, where does oxygen be carried in the body? It's red blood cells. It carries oxygen and iron, right? So what does the body do? It says, okay, let me produce more red blood cells, and maybe the oxygen will get around to where it should be, but there's still no oxygen, but you have a whole bunch of red blood cells. Your hemoglobin hematocrit could be 18 and 54. You're going to see the darkest red blood you've ever seen when you're talking about a cyanotic congenital heart defect, okay? That's polycythemia. I want you to know that probably of all the families, cardiac children's families are all wonderful. They just are. And they're thirsty to learn. And as you do anything, discuss it with them. These parents got to take these kids home, know how to give meds, what to look for, what, to call the doctor for, et cetera, et cetera. I've already gone over cardiac cath and bacterial endocarditis. This is something that this child is going to be getting prophylaxis before procedures or dental procedures, et cetera. Now, rheumatic fever, and the reason why it's here in the heart area is because rheumatic fever can do permanent heart valve damage. This is the mitral valve. The left side can be damaged. Now, what causes rheumatic fever? Well, rheumatic fever is due to a strep throat that wasn't treated or not completely treated. And it attacks the body. And it attacks the joint, the skin, the brain, the heart. You're going to see polyarthritis. You're going to see rashing. You're going to see, again, still sore throat, swollen glands. And you're going to see something called chorea, which is these weird, you can't control the movements of your arms or hands. And usually that's what bring the kids in. They're like, I don't know what's going on with my child, but they're just not moving right. Now, everything can be reversed. How do you treat rheumatic fever? It's due to a strep infection. Long-term antibiotics. And usually it's IV long-term antibiotics. Everything, the chorea, the polyarthritis, all of that can all be turned around. But that heart valve damage, no, once it's damaged, it's damaged. It'll need medical or surgical care. Children do get high cholesterols. We treat it, diet, exercise. Cardiac dysrhythmias. Kids can have low, fast, or irregular heartbeats. I've actually seen the youngest kid was less than 2 that had a pacemaker. Little tiny little thing. It was quite amazing. You can feel it. They put it in the abdomen, not in the chest like adults. Pulmonary artery hypertension, it's called many different names today. It's just lungs that have been damaged due to whatever reason. And the arterioles get very thickened, and it doesn't allow for good exchange of oxygen and carbon dioxide, which means on activity, exercise, you're going to be short of breath, probably chest pain, and dizzy because you're not getting oxygen because those arterioles are so thickened and narrowed. Cardiomyopathy, as I said before, probably due to a viral state, could be due to lupus because it causes it, or any other thing. And usually cardiomyopathy ends up with transplant. And you need to know the largest reason for death is rejection. Most of your really sick cyanotic hearts, there's something called a hypoplastic left heart syndrome, which is the most severe of all of them, requiring 3-stage surgeries and all sorts of caths, etc. Many of them end up with hearts. And, I have some kids that still today, they're 20 years old now, that got a heart that are still okay. So it does work. Again, it's a long-term care, right? Now, post open heart surgery, all children will have a chest tube in. One of them, I've seen 5 in, depending on the size of the kid and what they do. And one of the things is taking them out, especially on your older children that are alert. Babies, not as much, they can't complain as much, but older children, they're going to be scared. So how do we take them out? Number one, get a set of vital signs, because we're going to medicate with whatever. Morphine is usually the drug of choice, or fentanyl is another drug of choice that we use. We're going to medicate for pain because it burns really bad, but for a little time. It's not a long time. Tell the child on their level what you're doing, and you sit them up for this. You don't lay them flat, you sit them up because you want that chest to be open, and let the kid know you're going to give as much as you can. Pain medicine, it's going to hurt a little bit, but it's that burning will go away in a second. And you want me to hold your hand? And most kids will say, yeah. Hypertension in kids, we're checking blood pressures on younger and younger kids today. And remember, kids actually do have high blood pressure. And if we get it earlier, we can prevent a lot of kidney damage, can't we? Because that's usually what high blood pressure will damage is your kidneys. Now, Kawasaki, it's a cardiac disease. It's a systemic vascularitis. We don't know why. We think it's a viral type thing. It's not bacterial. And it's the vessels, the vasculature gets inflamed. And what we're concerned about is microembolus and aneurysms of the coronary arteries. These children come in, they have fever, 101, 102. They don't feel good. They got this rash. When you look at them, their eyes are red. I mean, redder than you've ever seen. It's like almost glow in the dark red. Their lips could be peeling. Their tongue could be strawberry. The palms of their hands, the soles of their feet could be peeling. Now, Kawasaki can hurt the coronary arteries, so we must be aggressive. They're going to do an echocardiogram to make sure that it's okay. But treatment. This is IVIG, intravenous gamma globulins. We're trying to boost the child's immune system. And because of these microembolus, because this itis of inflammation in there, we're going to be given high dose aspirin. It's the only time we give aspirin. Now, they are changing thoughts. Some, not all physicians, are giving Coumadin, anticoagulants instead. But again, depends on the age of the child, et cetera, et cetera. But those signs and symptoms are what you see with Kawasaki. We already did that. Shock. I already told you one of the big things in shock in children is septic. Always think shock in children is that. What are your signs and symptoms of shock? Elevated heart rate, decreased blood pressure, decreased mentation, decreased capillary refill, decreased urinary output. I could go on and on, can't I? All of these things could be showing you shock. No, with anaphylaxis, it's getting to it quick and making sure that we figure out what's going on, given them that epinephrine or solumedrol or steroids or whatever they need. Septic shock is getting understanding the early stages. In infants, what is an early sign of septic shock? Apneas and bradycardias. That's exactly what you see. And when we start seeing them, we'll tell the doctor and they'll say, okay, let's get some blood cultures and let's start antibiotics. Another thing you might see is if they're feeding and they have tubes in, they're going to start seeing feed coming up where it was digested before. Adolescents, girls, can get something called toxic shock, and it could be from tampons. Now, think about this question, and I want an answer. Surgical closure of the patent ductus arteriosus would result in which of the following? What is a patent ductus arteriosus? It connects the aorta to the pulmonary artery, and it gives the body oxygen. So if we cut off that, it's going to prevent that left ventricle who's pumping blood up that left up the aorta. It's not going to go up into the lungs anymore. So it prevents going into there. as I told you, huge concepts, lots of stuff today. Any questions regarding all of that? No, I've got a cahoots, but it's a huge cahoots. And I can be sending that to you. Is there anything that you all want me to go over with you? Is everybody okay with math? Are you all understanding that? Do you all need help with that handout that I just gave you?
Mines won't download. It says I don't have access. I don't have authorized access.
Yeah, mine says
Really?
the same thing.
Well, that's crazy. All right, let me do something. Let me re-download me because I just pulled it up and it did it. Thank you for letting me know. Wow, this is going crazy today.
I downloaded it from the chat and it worked for me.
You did. Okay, good. What I'll do again also is I'm going to reattach it. You know how I take your whole day and I'll put your PowerPoint handout. I'll put it out there for you too, okay? So I can't do your Kahoots today. It's too long. I'm gonna let you go early today. I'm gonna give you your Kahoots. I do have a recording from last night. It's a longer class. So I was able to finish the Kahoots in it. So I'm gonna send that to you and you could go over that, in your own time. Any other questions? Remember that this week you do have a discussion question as DJ Sims. And next week you do have another quiz. It'll be quiz 4. And next week starts reviews again for exam 2. Again, anybody who needs to see me, send messages. Usually great on Wednesday and Friday afternoons are usually good times for me. Send me a message what's good, what you want to do, so that I can help you get through this course. I want everybody through it. So if you need help, just let me know. Thank you, everybody.